It's a pleasure being here. I know a lot of you, and some of you I don't, but it's wonderful to see doctors engaged. One of the things I always did with the WAFP, the family doctors, when I worked very closely with them, was to get them actually talking to the legislators. So we get, it's interesting how much influence you folks have. And I love the issues you're taking up this year, in the sense that they really are things that make a difference to the people of the state. So start with that. Let me tell you what I like to do anyway, is to talk a little bit about how we're looking at the session. As you know, there's a few ripples going on the last few days, which have caused a few problems. So we're thinking about those. But really, what we try to do is get some things done. This year, we're really looking at a budget. The budget is a tough one. We didn't put much in it, and we considered, as we did last year, a lot of the rate increases. The Medicaid, we put in the primary care bump last year, and we did not get it. And so we're pretty concerned about what the rates are going forward. We made a decision, though, this year not to make this year a rate issue year, just because we had no room in our budget. We had to cut other things out. Next year is going to be a bigger budget year. This is really a supplemental. But I think the issues are really important. One of the things everybody, we all get unhappy with Medicaid, and really, what we're really unhappy with are the rates, the way this thing's structured. And the rates have been really driven by the budget and the legislature in this desire to cut funds, basically cuts Medicaid. And they do it kind of surreptitiously, or we do it, I guess, as a group. But we do it by just letting inflation take care, and we don't update the rates. So that's been a problem, and it's been a problem with some access issues. So this is something we're trying to figure out how we address. I would like to make that an issue for next year, but we're not going to. I doubt if anything's going to happen this year, though it's a good issue. One of the things that we are working on a lot, though, is the issue of vaping and access to different, I'll say, chemicals, if you want to call that, in different ways. So we have a vaping bill, which the total bill would have both regulatory and taxation. The tax is there only so we can regulate. I mean, one of the interesting things about this is you can't really regulate unless you have somebody there to kind of look over people's shoulders. And so you need to have some sort of source of revenue to do that. But the vaping issue is really, I think, really important. As you know, all of us have fought very hard to get cigarettes out of people's mouths and out of kids' mouths. And now they've substituted it with vaping, and they're putting a lot of different substances, mostly nicotine, but we know that there's a fair amount of marijuana and probably a lot of other things thrown in. And there's a lot of good evidence to show that vaping, at least there's a recent study done, I shouldn't say a lot of good evidence. There's one recent study that shows that people who vape smoke more, especially adolescents. And so rather than being an exit or an alternative to, it's an entrance mechanism to start smoking. And I think it's really a problem. So we're trying to address that. We have some discussions with the Senate, which is a much more, I'll say, voluntary bill that doesn't do very much, but it does start the right direction. We have a House bill, which is pretty good. And then there's a separate taxation bill. So we're hoping to move on that because I think it's an important thing to do. The main work we're really doing in the administration right now is it's administrative. We are doing a lot of work around the Healthier Washington work, which is looking at how we actually make our health system work better. One of the things, we've always, everybody in medicine is worried. I guess everybody has different opinions on things, but we haven't had really great outcomes. We've had a lot of problems. We have people who fall through. We're now being, more held to our feet to the fire for doing active management, making sure our diabetics, for instance, have better outcomes, make sure our different folks are actually, their preventive care is taken care of. And, to do that, we're getting to the point now where people are looking at, well, what's the outcome? Are we really making a difference? And so the Healthier Washington activity is trying to combine a whole series of things, which is looking at getting some good numbers about, what's the cost of care, for instance. And I appreciate the support last year when we got through the All Payer Claims database. We got that in place. It's now in RFP status where they're going out for another RFP. But that will move ahead. We'll have that information, but we'll also have a lot of quality information, other things that are collected in different forums. And we're putting that together in one way that we can actually measure whether or not we're making an impact. And also to inform providers about what are the costs of different things, as well as the quality outcomes, so you can adjust what you do to get the best outcomes as well. In addition, we're looking at how we help practices change. There's a thing called the Hub, which is based out of the Department of Health, and that is, like my clinic at Harborview that I ran for a long time. We actually went through the whole, what they call the primary care collaborative, I think they called it, where we actually ended up bringing mental health in. We integrated the care. We changed the way we did our practice. We elevated our, actually much more team-based. We got all of our staff engaged. We ended up, instead of having one QA project at a time, we ended up having 12. We ended up moving our preventive services from about 50% compliance, which is typical around the state, to about 80 to 90%. And that was done because we didn't involve the doctors, but we involved the medical assistants. But there are those kinds of changes that really make our practices better. And what can we do like that to help everybody's practice be better? So that's going on as well. We're also doing purchasing differently. We're trying to get away from a fee-for-service model and move more towards a quality outcome model. And so there's a lot of work on that. Right now we've done it through the PEB program, which is the employees' benefits. And there we have a couple, they call them AC, accountable, but it's not AC, it's not ACO, ACP, it's a plan. That's right. But it's a accountable care plan. And so we have two of them now, one with the university, one with VM, and their constellation of providers. But the idea is we're trying to step into this, trying to figure out how do we actually pay so we improve the quality and benefit people who have better outcomes, and not benefit people, not necessarily pay more for poor care. So that's going on, and I think it's actually a very good thing to do. Along with that, there's a lot of work done at the community level. One of the things in healthcare is we could do a lot of things, since we're a big purchaser, we could conduct a lot of things and tell people what to do, but we want to figure out how do we change that, get communities really engaged in their health more broadly just the care, and figure out what are the highest priorities for communities, and then direct our resources towards that, and developing some virtuous cycles where we actually can invest in things, get things started, and they can continue because there's a good ROI. And what I'm thinking about is like in behavioral health integration, we know that if we get that in place, we actually end up with lower costs, actually in things like diabetes, hospitalizations, congestive heart failure. But how do we get those reinvested upstream, those savings, so that we can continue that? So that's what that process is looking at. And so 1115 is a way to get some money from the feds to invest upstream and to start that cycle. We're in discussions with the CMS right now on the amount. They're pretty much agreed to the general format of that work. And the biggest thing that I have to worry about now is the behavioral health integration work, because there's a lot of work being done at the local level, but we have the state, which has two separate agencies and are not really working very well together, and we need to bring them together better, make it functionally integrated, and maybe structural changes. We have to make sure our financing is structured so that we can actually do those investments upstream. And we have to make sure that reflects how we actually do good, I'll say, behavioral health integration at the front end. And that's really a huge, every one of these is a huge cultural shift. I mean, we're talking about managed care organizations in our Medicaid program that have typically not done a lot in behavioral health. We have to get them geared up. We also have the separate groups with, we call them the RSNs, and how we integrate all the severely mentally ill. So there are a lot of things going on with that we're looking at and working on. And I think it's actually, it'll not be perfect, let's put it that way, but it'll be hopefully a lot better than it is today, and we're working very hard on doing that. And all the agencies engaged are working on it together. We're working with the managed care organizations, working with the RSNs, legislature, and other people. So it's a pretty heavy lift. Now, your issues that you have, you're interested in, you mentioned the Medicaid rates. The loan repayment program, we have been supportive of and helped get money in last year. We actually targeted last year to go to behavioral health and primary care in our budget ask, but it came out more generally. There's a lot of interest in expanding that into behavioral health related professions. So I think there may be something that will come along with that this year. It's a really interesting thing about behavioral health where I had the same job 25 years ago, and behavioral health or mental health was considered to be, yeah, we have to worry about it, but somebody else. And over the last 25 years, people really changed. And now it's really us, it's my families. And so there's a bipartisan support for doing things. There's not a bipartisan support for money necessarily, but there is. But there is. People do recognize it and do want to do something about it. The other thing I know that you care about a lot is the smoking at 21. And as you know, the Attorney General has proposed that. We have been, I'll say, supportive of that for the last couple of years when it's been out there, and we are continuing to be supportive. We are not the lead on that, and not because we don't necessarily agree with it, but just it's a matter of division of labor, if you want to call it that. The governor can take on so many issues, and the Attorney General is taking that one, so we've been supportive of it. I think it's a very good idea. It's a very tough one because you have a lot of small retailers that make their money off of cigarettes. And they're the ones that you basically undermine their business by doing this, or we undermine it to a certain extent because they make a lot of profit out of that. We'll have a lot of pushback on it. It actually is a good policy. We know because we know that a lot of 18-year-olds still are in high school. There's a lot of conduit from 18-year-olds to younger kids starting cigarettes. So I think moving it up is good for those kids that we say between 18 and 21, but it's also good for the youth at a younger age.